panel discussions are innovative. It's a great benefit for anyone who takes the time to attend this meeting.
And there was a very practical handling of how to use imaging, how to make interpretation.
Also, it touches various topics, both on the coronary and structural side. Very insightful, exchanging scientific data and results of trials.
And several live cases have been performed to show complex, innovative procedures. Several workshops were Good morning, everyone, and a warm welcome to all of you. I know some people are quickly finishing their breakfast and joining us, and we would like to stay in time. And we have some exciting sessions lined up for today after yesterday's whole day of very interactive discussions. And so I welcome Dr. Gary Rubin, Dr. Eberhard Grube, and Dr. Sasko Kadev. They are with me as to moderate this session. And this session will be on innovative impact therapies. And we have a galaxy of speakers, which will start with Giza. So may I also invite the chairpersons, Dr. Himanshu Gupta, Dr. Anant Raman, Dr. Claire, Dr. Sushir Soni, Dr. Babu Ezomalai, Dr. Barun Kumar, Dr. C.B. Meena, Dr. G.R. Kane, Dr. L.C. Daga, and Dr. Rahul Singhal. So, and as people keep trickling in, so we'll ask them to join us on the dais. And over to you, Gary, to invite the speakers.
Thank you. Good morning, everyone. It's a great pleasure to be back here this morning. And I would like Dr. Geza Fontos to come up and give us these insights into post-TAVR PVL closure. Thank you.
Good morning, everyone. And the topic of my presentation was post-TAVI PVL closure. We have more and more evidences that proves that even the mild PVL will kill our patient in the long run. Let me start by our local protocol on PVL assessment and management. So if we have none or just traces of PVL, we can be happy. But on the other hand, if we have a moderate or a severe PVL, we have to do something right on the table. If we have a mild PVL, we need to make a decision, a case-by-case decision. I'd like to show you what else. This is not the last version of the presentation, but anyhow. So if we fail and we see that we are ideal position of the device, of our the TAVI valve, and we did everything with the balloon post-dilatation and still we have at least mild or more PVL, we have an option of device closure. We can have two approaches, a retrograde from the arterial side. I did all of my cases with this approach. Theoretically, we can use the transapical approach as well. These are my most important tools for crossing and delivering. I don't want to go deep into details. I'd like to underline only two devices. One is the Asahi sheetless guide, which is a hydrophilic coated guiding catheter, which has a very nice dilator. There is no step in between the dilator and the catheter. We can do the implantations of all sizes of AVP2 and AVP3 with this catheter. The crossability of device is just beautiful. And the other catheter is the Merit Impress catheter, which is a 5 French diagnostic catheter, which is also a hydrophilic coated catheter with taper tip, and all sizes of the AVP4 can fit into this 5 French diagnostic catheter for all the residual leaks. These are the most important plugs for closure. In my experience, at least 80% of the PVL cases I do with AVP3, but sometimes AVP2, AVP4, Occlutech PLD or the Conar devices are the best options for certain anatomies. I'd like to show you 3 cases. The first, the typical TAVI case with a critical aortic stenosis, pure ejection fraction, an 85-year-old male patient. he already had a grade 3 aortic regurg, and as you can see, extreme amount of calcium in the root and also extending to the LVOT. After a lot of post-deals and a good valve position, we ended up with a severe paravalvular leak, as you can see, which was at the left coronary sinus. And the reason you can see from the transesophageal, there's a huge calcium rock, which doesn't let the valve to expand fully. It has a kidney shape at the inflow edge of the frame. Since the patient had already a grade 3 aortic regurg, we had time to do a CT to assess and to understand what is the reason, the mechanism of the PVL. And as you can see, there is a lot of calcium around the valve frame. There is a winding cave around with a lot of calcium and a lot of rocks and a lot of gaps in between. So it's not a classic PVL, what we usually see with the surgical valves. So my strategy was to choose a device which has 2 discs, which covers the LV part and the aortic part, and something that fills the gap in between. With the high frame valves, I tend to choose the highest struts to go through. It's easier to manipulate afterwards. I was not able to cross with the THERAPIES wire first, so I had to use a Pilot 150 that could go through the channels. After that, I could use the stiff THERAPIES wire, and through the stiff THERAPIES wire, finally, the Merit impress catheter went through, which helped to go down with the Confido wire. Over the Confido wire, the Asahi sheetless guide 6.5 went in easily. And this is the implantation of the AVP2 device. You can see that I opened the LV disc, pulled it against the inflow edge of the frame. On the second cine, you can see how we open up the mid part inside of this calcium around the skirt of the frame. And finally, we open up the aortic disc. And once we confirm that we are okay and we are away from the left main, we just release the device. This is the angio after the first device, where you can see that we still have some leakage, which is around mild. So I went back with another device. The same way, it was the Merit impress catheter which went through the channel. And since it was a very tiny residual channel, there was no chance to go through with a larger catheter. I went for an AVP4 device. You can see the AVP4 device implantation and deployment. And after that, the PVL came down to 0. The second case, and this is how it looks like, just to learn from the procedure, we repeated the CT scan to show how the devices are aligned and how we could close the PVL. The second case is an old female patient who had a Navitor implantation. And at that time, with the moderate PVL, we decided to stop the procedure, but the patient came back with worsening heart failure. As you can see, at least moderate PVL the patient had. And we did the CT scan to measure the leak and to understand again what the mechanism was. There's a huge calcium chunk, and it was around the non-coronary cusp. We measured 1 centimeter by 4 millimeter. So in this case, you can see the angio as well. The huge PVL crossing was easy. It was not that difficult as with the previous case. And since it was a nice oval-shaped leak, we decided to use the AVP3 device. As you can see, after implantation, the PVL was gone completely with 1 single device and a 20-minute procedure. The third case was done, if I remember well, it was in Slovenia. The young patient who got a sapien implantation, and the patient was discharged despite of the moderate PVL, but the patient came back with heart failure and hemolysis a couple of months after the procedure. So we repeated, we did a CT scan which showed that there is a leak around the frame, again in between the calcium chunks, and it was in the deepest point of the left coronary cusp. As you can see from the angio, the frame of the Edwards was above, the outflow part was above the left main. So I had a fear that if I go outside of the frame and close the PVL, the aortic disc will cover the ostium of the left main. So this is why I went through the struts of the outflow frame, implanted the device in a way that the ventricular part was sitting just in the leak, and the aortic part was inside of the frame, away from the left main. In this position, we got some leak in the end, which is not more than mild, but at least we could keep the patency of the left main. So in conclusion, we can say that compared to the surgical valve replacement, PVL is more frequent. It can improve over time, but we should tailor our therapy to each patient depending the age of the patient, the degree of PVL, the existing aortic regurg. We need to understand the mechanism of the aortic regurg, and we need to understand the particular anatomy. So, of course, the aim is to have an ideal valve position. We need to do everything which is reasonably doable with the post-dilatation, but it's not always effective. In case we fail even after ballooning, we still have an option, which is the device closure for these procedures. Thank you.
Beautiful, beautiful cases. Any questions or comments?
These are fantastic, as always. Whenever there is PVL, there are only two questions you have in mind. Should I post-dilate? Should I plug it? How do you decide?
Yeah. So at home, we don't end up a procedure without the ideal final result, which is achievable with device position and post-dilatation ballooning. Then if we still have a PVL that is larger than mild, so at least moderate or severe, we nowadays put a plug right on the table. If the patient already had a PVL before and we have time to make a decision, then we take the patient off the table, do a CT scan. It can give, as you saw on my presentation, a lot of additional information on device size and device type selection. And then we do the procedure a couple of days after the TAVI.
Because this is very crucial for the audience. When you post-dilate, you will end up causing annular sort of rupture risk. So it's very important to understand if there is a big nodular calcium or something which is not allowing the valve to post-dilate, don't be aggressive to post-dilate. Those cases are the ones like Giza has shown. You just plug it, you will get a fantastic result. Otherwise, those are excellent results. Thank you.
Giza, I have one question. So once you're doing ad hoc planning for PVL closure, if on table it is there, so do you convert it to GA and put the transesophageal echo and then do it?
Yes, at each case, when we finish up the procedure with the post-dil and still have PVL, we have the TE probe and we go down to look around to have a more precise diagnosis. So never do a PVL closure on the table without at least a transesophageal echo.
Okay. And second one, how do you choose between AVP3 or AVP4? I mean, without CT. I mean, can you decide AVP3 or AVP4?
Yeah, we can decide if it's an oval crescent type of PVL, then my first choice is the AVP3, which is the oval-shaped device. If there is a large hole, as like in the first case, and there was a huge leak with the serpiginous channels, then I try to put an AVP2, which has two discs on the two sides, and in the middle we have something that fills the gap. And the AVP4 I use for the residual leaks, because it's ideal for just putting something in to fill a small gap.
So recently, Giza, we had a case of bicuspid aortic valve about a year and a half back who had undergone TAVR and with a balloon expandable valve. It was an extra large annulus. So at the time of the procedure, it was a perfect result, no PVL, no AR. So down the line, in a year and a half, when he came for follow-up, he came with breathlessness, increasing breathlessness, and he had developed a significant PVL. So this, we presume, should be part of the pathology, the bicuspids. Are they known to have late PVLs? Have you noticed that phenomena? Because initially everything was fine, and then the aortopathy must have progressed in this case.
Yes, but we learned that with a bicuspid, we can get almost the same result as with tricuspids, but we can expect to have more PVL. I only remember one case when we had a late PVL, a late compression of the frame. It was also with a balloon expandable valve. I think it's extremely rare. In this case, we went back with a PVL closure, so it's doable. But first, you need to exclude that there was no endocarditis, because we don't want to implant a new device in the infected environment.
So in this case, we were in a dilemma as to how to go about treating it. There was a discussion between a balloon post-dilatation, because we could have upsized this valve, versus plugging. But then we have an apprehension that now, after 1.5 years, if you try and do a post-balloon dilatation, we might injure the leaflets. So we chose to plug.
So most probably, if the reason was that the patient was just stronger than the radial force of your balloon expandable valve, then another ballooning would not help. You can do two things, I think. First, implant a second valve, and you can double the radial force, or plug with a device.
Right. Any more comments?
So your conclusion slide shows that PVL may improve with time. So generally, how long do you wait before attempting for a device closure following PVL in a TAVR procedure?
Yeah. So basically, the manufacturers of the self-expanding devices are saying that it will improve over time. But if you have an extremely calcified anatomy, then I think the chance of improving is minimal. If you have a more fibrotic or less calcium, but still you have some mechanism of mild PVL, the mild PVL can improve over time, but moderate or severe, especially in a calcified environment, will never improve.
Giza, when you anticipate of putting multiple devices, because you know that the defect is large, do you put multiple wires, or each time you cross after every device that you put?
Very rarely. Usually I put only one wire and take the catheter which can cross, the smallest catheter that is still doable with a device size. For example, for most of the post-AV PVL closures, I use EVP3, and the size is 10 by 5. The reason is that it can still fit in the 6.5 sheetless guide. The larger needs an 8.5 sheetless guide, which is a much more bulky device. So I try to choose my device based on the largest.
No, but when you want to go with the second device, if you have to recross, is there a danger of displacing the first device?
Yes, recrossing can be challenging, but if you cannot cross with your hydrophilic wire, you can try to do it with a PCI wire or a 0018 wire. Finally, anyhow, you will be able to cross if there's a significant leak.
Thank you.
So is there any increased risk of a stroke, especially in the younger patients, if you put multiple devices? Is there any chance of increased risk of a stroke in the long term?
Stroke?
Stroke risk.
Altogether, I did like 15 or 16 PVL closures after TAVI, and there was no stroke at all.
Yes, one practical aspect. Since recrossing with wire is one of the critical points of this procedure, have you considered coming from cranial side? Because sometimes using this cranial side can provide more predictable torqueability, and maybe you can try advantage type of wire, which is extra stiff, a hybrid wire with a floppy segment and extra supportive part.
Yes, for crossing, my primary wire is a Thermo super stiff wire, the brown Thermo wire, which is a flexible distal part, but the shaft is very strong, like an Amplatz extra stiff. And this wire is, I think, the best wire for crossing. And what is important, and I didn't point previously, is that from the CT, we can define which is the implantation angle, where you can see that the wire has to be outside of the frame in the calcium. Otherwise, if you are in front or behind of the frame, you will never know that you are intravalvular or paravalvular with your wire.
Thank you very much, Geza.
Thank you.
Very excellent, as always.
Thank you.
And the next speaker, Dr. Raghi, will be talking about rescue PCI after cabbage. Kapoor? Okay, so then the next one, TAVR and AR. Oh, Dr. Kapoor, here he comes.
Thanks, Dr. Grube, and compliments to Dr. Mathu for pulling off a nice conference. Sundays is usually a time once we meet on a tennis ground, but here we are meeting here. So thank you for having me here. And I'll be speaking upon TAVR in pure aortic regurgitation. So we all know, we have been doing TAVR now for many years in aortic stenosis patients, and that's the on-label scenario. I mean, it is indicated, it's basically started with aortic stenosis, calcified aortic valves, but then off-label we come across many patients where the AR is a problem and the patients are not deemed surgically fit. So what to do in such cases? So in certain circumstances like this, we are doing a TAVR in pure AR also, where the valves are absolutely not calcified, anchoring is an issue. So there are challenges, but then we have to do TAVR in certain subsets to salvage them. So that's what I'm going to speak upon and show you some of the interesting cases. Overall, now as per our experience, I have done around 14-15 TAVRs in pure AR and with very good results. But then this doesn't mean that guideline is that we start considering TAVR in all AR patients. No, it has to be very meticulously analyzed before that whether it's a fit case for trying a TAVR in pure AR. And then obviously until the time it happens, the catecholamines continue to increase your heart rate of the operator also. So what are these challenges? So once we talk of challenges in aortic regurgitation patients, obviously we are looking at a valve which has no calcium. There is increased stroke volume. The aortic root dilatation increases the risk of valve malposition, migration or embolization, leading to complications. It could be, valve embolization actually can lead on to all the spectrum where life threats also would be there. So in some of the studies, the incidence of valve migration or embolization has been reported almost close to 20% in AR cases, up against 0.1% rate reported in aortic stenosis patients. So this is one area where we have to be very careful, and it's a typical challenge once we plan such cases. So if we are dealing with the pure AR case, obviously surgery is the modality of choice. But then if the patient is of prohibitive surgical risk, then how do we look at it? We can consider TAVR with the meticulous planning. So we have different valves. But one important key parameter which we have to keep in mind is to look at the annulus. So this chart also gives some of the dimensions of the annulus. Look at the Medtronic evolute. If we have to try the self-expanding valves, the annulus has to be less than 94.2 perimeter, 94.2 millimeter of perimeter. If it is more, it is unsuitable straight away. And Accurate Neo, now Accurate Neo is not with us, but it was a beautiful valve. I don't know, it has been taken off. Again, with Accurate Neo, so I'll show you cases of TAVR in AR with all the different valves. So annulus of up till 85 millimeter perimeter could have been attempted by Accurate Neo. And if we talk of balloon expandable, look at these areas, up till these areas we can attempt that. Obviously Merrill, my valve, takes a lead here also because they have a valve with 34 size, and then we can go up to the annulus area of 840 millimeter scale. So up against Edward Sapien, which can be only tried up till 680 millimeter square of area. And then there are some dedicated valves. Unfortunately, we don't have these dedicated valves in India, J valve and Jena valve. So this is, until we don't have this, we have to continue struggle with TAVR with these available modalities, these available valves in pure AR. So again, these are the different valves I talked of. This is mechanism of an anchoring method with J and Jena valve. It actually anchors with the leaflet, you know. This is how it is done, but I'm not here to speak upon that. So this is one study I like to highlight before really showing you the cases. This is a Pantheon registry. The TAVR embolization was almost 12.4% in these patients, where almost 200 patients of TAVR was done in solo pure AR. So still quite a sizable embolization. So that's where our planning has to be there so that we can actually escape this disastrous complication. So tips and tricks, if I have to talk about, a careful planning and a CT assessment is the key. Peri-procedural T guidance again is very important, and of late, you know, I started without a T, but last 7-8 cases I have done with GA and T guidance. That helps. That definitely helps to improve and escape this embolization. Some use 2 pigtail catheters, but I use only 1 pigtail catheter. Balloon pre-dilatation is not required. We are already with the high stroke volume. Rapid pacing is again very, very important. So we have to have a blood pressure absolutely down with rapid pacing once we are going to deploy this valve. And a special attention to hemodynamic profile is again important. So extra volume, upsizing of the valve is again very important. So I haven't done any case without upsizing 20% of the aortic annulus. So these are the few of cases. I've selected 3 cases with different valves, all different valves. So this was the patient profile, a 68-year-old male patient with recurrent heart failure. He was getting readmitted many times in our hospital with heart failure for 6 months, almost 4 or 5 admissions, very frail patient, 40 kgs. Surgery was absolutely ruled out. He had already undergone a cardiac surgery where a surgical mechanical valve was in situ at mitral position. And this time there was a severe aortic regurgitation, which was a culprit for LV dysfunction. His EF was 15-20%, dilated LV, and severe AR leading to recurrent heart failures. So we kept on treating him for a few months, and that's the point where I discussed once the surgeons have totally raised their hands. So that's where I discussed that this is one area which may be slightly risky. This is done about 5 years back, 4 years back. So that was the initial days once we started TAVR in severe AR. So this is the echo, and these are the dimensions. So as I mentioned, perimeter and area is very important to look at. So perimeter of 79.3 and area of 455, well within our reach where we can plan TAVR in AR. No other issues at all, the coronaries were fine. These are usually dilated anatomies, so there are no basic other issues are not there usually. It is the annulus and the anchoring. That is the key thing which we need to look at. This is a CT Mancio, look at that, 0 calcium, and here we selected a Medtronic Evolute Pro valve. That time Pro was available, 29 based on the annulus perimeter. And this is the valve again I'm showing, and look at this. So this is the procedure. So access taken and coronary chutes were taken, and look at, as I mentioned, the surgical mechanical valve is there at the mitral position, and very slow gradual deployment. Again, be very careful. Slow gradual deployment. We selected Evolute at that point of time because at 80% we can just keep on waiting for some time before really releasing it, whether it is stable or moving. So this is how we waited almost for 5-7 minutes in this position. It was pretty stable. With the rapid pacing, we deployed this valve. It was fine. It remained stable, and we could actually cure aortic regurgitation. No conduction disturbances. Commissural alignment was done absolutely at that point of time. Now, as you know, the complexities keep on happening. This patient again landed with the triage in our emergency 2 years later with the acute coronary syndrome now. So patient had chest pain, ECG changes, cardiac markers positive. Taken for angiogram. Through this, obviously through the valve, the stent struts of the valve, and look at this, there is a tight left main. There was some lesion at that point also which was 40%, which has now progressed over the 2 years. So fixed this with a PCI through the valve with one left main stent, and patient did well. So this is almost a 5-year-old procedure where patient was recurrently hospitalized many times. After this, patient did quite well, and he's still carrying along well. There is some LV function improvement which has happened over the time. So this is one case with the Medtronic valve of pure AR. These are the post echoes. Okay. Now this is the case number 2, 67-year-old patient. Again, having lots of symptoms for almost 1 year. He was roaming in many hospitals for a possible solution, but nobody really considered that perhaps. Now, this guy was again surgically turned down for severe AR because the guy had liver cirrhosis. So other comorbidities were there, but liver cirrhosis was the main issue where surgically consideration was not taken. I mean, that was not proposed. So severe AR with LV dysfunction, and this is the echo. Look at this, a severe florid AR. And this is the CT Mansio. Again, area and perimeter, look at that, it is fairly in consideration. Coronaries were no issue, zero calcium. And this is what I am trying to show. Is there a highlighter here? Okay, I'm not sure how to look at it. Okay, yeah, so this is here. So now look at this, this CT. This is very important. Now, if we are doing these tough cases, we have to look at the LVOT dimension. If the LVOT dimension is almost the same as the annular dimension, that is a favorable thing for a planning of a TAVR in pure AR. Because we are looking at if we can have a grasp at 2 positions, one at the annulus and one at the LVOT. The valve, chances of valve stabilization is more up against if the LVOT is very dilated. So in this situation, the LVOT and annulus were absolutely same. So it almost forms a tube. So that's what we learned over the time, that this key parameter we have to look at once we are planning a TAVR in AR. Again, a zero calcium, femorals were fine. So this is with the Merrill valve. So this is aortic root angio positioning. I was specifically very, very careful in positioning the valve 50-50, not as 20-80 or 70-30. So it is much lower down into the LVOT because I was attempting a grasp at the LVOT area also. And then with a very rapid pacing with pressures almost zero, so this is inflation being done, and specifically if you decipher, I'm looking at to have a grasp at the LVOT also. Otherwise, these valves may become unstable. Look at this. So now almost a 50-50 deployment, and this was very stable. Again, this is 2.5 years back. Patient is doing absolutely fine.
Rajneesh, can we have a discussion now?
Okay. I'm showing this case last. So this is another case, 61-year-old, chronic liver disease, portal hypertension, severe AR. This case planned with accurate neo. Now this is a beautiful valve to be attempted in a severe AR situation because we have a better control. We open the upper part, upper crown first, and then we can just open the lower crown and the valve remains usually stable. But unfortunately, this valve is not there with us. So again, a good end result. TAVI in severe AR with newer generation devices is feasible with the acceptable risk of complications. Percutaneous intervention should be considered after a careful patient evaluation and obviously a meticulous analysis of the CT. We are going to have more dedicated valves where we can actually give a lot of relief to these subset of patients who are surgically very high risk. Thank you.
Excellent. Beautiful. We'll take 2 quick comments, Eberhard, on future of valves for the aortic regurgitation.
Yeah, thank you very much. Obviously, that was a very excellent summary of things that we can do, at least in those countries that don't have dedicated devices. I tell you, the aortic insufficiency is really a special animal, and we know that we can do it with THVs, conventional THVs, but we also know this is like handicapped person walking with a cane. It's the best we can do, and the dedicated devices are getting rid of all these problems. Unfortunately, you don't have them. We have them in Europe. Unfortunately, there's a little bit of a transition because Edwards acquired J-Valve, and the FEC is still deciding whether Jenner would go to Edwards or not. But the point is that I'm trying to make, you can give many advices, and you summarize this. The only thing that I would like to add, by choosing the valves, conventional THVs, we know the statistics, 2/3 leave the cath lab with about moderate AR after the implant, and in about 28% we need a second valve. The point that I'm trying to make is when you have a short valve, which is the way we go today in the development of THVs, in AR it's a little bit risky because you have only one shot. You do the balloon expandable, whether it's Edwards or my valve, if that valve moves, there's not much you can do except you have the second valve really ready to go ahead quickly and secure the first one if it moves. That's why I like to use larger valves, because with a larger valve, simply you have a little bit more time when it migrates, then you have more time to secure it. The question that I have and the advice that I would like to give apart from rapid pacing, don't stop rapid pacing, just reduce the frequency. Otherwise, you have rapid pacing, then you stop it, you have this sudden volume pushing the valve up. That's something that I would like to add to your advices.
Thank you very much, Rajneesh. Please join us over here, and while you make your last comment here.
So this is very important, the last point, and in fact we also learned, not in AR, we had one pop out with sudden drop of pacing. So now usually what we practice, that we are not doing a sudden drop of pacing. So 180, 190, we come 140, 120, 100, and then slowly take it off.
Yeah, can I just add one thing,
sure.
Atul? If we look at the conventional treatment of aortic regurgitation, it's almost dramatic. This group of patients is heavily undertreated. Even though recommended by guidelines, and we have excellent results with surgery, even let alone the THVs or the TAVR situation, even in the surgical cohorts or in the surgical world, we are undertreating these patients for whatever reason. And we can see now something very interesting, and I'm sure this is going to come up in those countries that do have these dedicated devices. All of a sudden, you see aortic regurgitation patients coming up, and they're coming from all corners, and the numbers are increasing. There was always a question, is this really a big market compared to aortic stenosis? It is a big market because, number one, we are undertreating it with surgery, let alone TAVR. We only take the TAVR when really the patient is in almost end stage. So once you have those devices, and those two devices that are out, they're beautiful. They're very easy to deploy, very easy to handle, and they simply eliminate aortic regurgitation. All of a sudden, you see the numbers are coming up because now you have a treatment option. You don't have to take the last ones out on the field, but now you can move into the intermediate risk. And basically what we try to do now in the countries that have those devices, do the imaging to see when to intervene. That's the question. We know that we are doing this too late, at least with conventional TAVRs, but now we're moving into the intermediate risk patients, looking at MRI, looking at the myocardium, looking at fibrosis, all the stretch factors. So this is a very fascinating field, and I would hope that you will have these devices in India very soon.
Over to you, Dr. Hani Reggie. That's your presentation.
Thank you very much, Dr. Atul, and I'm sorry for the confusion about the start time. I'd just like to talk very quickly about standby PCI for bypass patients. I work in a cardiac surgery hospital, which even in the era of PCI performs no less than 1,000 bypasses per year. And I just like to briefly touch on the subject and give two cases with a 15-year clinical follow-up. Having said that, CABG is still the default technique for left main with 3-vessel disease or 3-vessel disease involving proximal LAD, especially in diabetic patients. And this presentation is actually about patients who require PCI following bypass. But predominantly, obviously, I'm talking about very early post-bypass, including day 0, just a few hours post-bypass up to the first few weeks. My first case was a 56-year-old man who presented with an inferior non-STEMI, and his angio revealed critical proximal RCA disease and severe left coronary disease and excellent targets, CTO of the circumflex, and excellent targets for bypass. So even though he was an ACS, he was referred on that day for bypass because he was very suitable. But 7 hours post-bypass, the patient developed cardiogenic shock and acute STEMI in the inferior leads and was ventilated and was put in intra-aortic balloon. And that is an issue because at this point in time, the cardiac surgeons were thinking of taking the patient back into the operating room. And a very quick heart team at that time, we decided to take the patient to the cath lab. And this was his pre-bypass coronary angio with severe LAD disease and CTO of his circumflex. And here's the LAD disease, excellent targets for bypass. And this was his RCA, and he had a non-STEMI with some inferior changes. His left ventricular function was good, and he was good for CABG. He went to CABG. 6 hours post-bypass, this was the patient, ventilated, intra-aortic balloon, shocked at 2 o'clock in the morning. At half an hour later, 4 stents later, the patient pulled through. And it was a PCI on the same evening of his bypass. Inside the cath lab, the patient immediately improved hemodynamically. We gave fluids. We managed to wean him off the ventilator and the intra-aortic balloon pump in less than 24 hours. He was discharged to his CCU, from the CCU to his room in 3 days. He was discharged from hospital, and I've been following this patient for the last 15 years, and this patient is continuing to do clinically well. Is active, normal left ventricular ejection fraction, asymptomatic, still angry at having been sent to bypass. My second case is very, very interesting because it's a 47-year-old diabetic male with severe angina who had severe 3-vessel disease, including proximal LAD, a very good left ventricular function, was referred to a brilliant surgeon who does all arterial grafting, who performed all arterial revascularization, including Lima and Rima and radial. No veins were taken. 1 week post-bypass, the patient had severe crippling angina. His left ventricular function was still okay, and his angio showed occlusion of both the Lima and the Rima and his native LAD. So this was his pre-bypass angiogram. And you can see there's an apical total occlusion of the LAD and a proximal tight stenosis. And it's important because when we revascularize him, we didn't go near the apex. This is the proximal LAD and the apical LAD and the obtuse marginal. And he had this focal lesion in a very large RCA. This is 1 week post-bypass. All grafts are gone, and I'll explain why. And the native LAD is gone. But of course, it's not a CTO, it's a 1-week-old occlusion. Here you go. And of course, the patient was extremely symptomatic. The RCA was the same. Here, the Lima is going nowhere, and we selectively cannulated his grafts. None of them were working. ad hoc angioplasty, of course. It was pretty easy to wire. Still, we use the Fielder FC. And IVUS was used, and 3DES later in the LAD. The LAD was revascularized. We left the apical segment. The RCA was actually done at that time with a large bare metal stent, and continues to do well. So this was a successful PCI using IVUS guidance with 3 drug-eluting stents for the LAD. And the patient, again, is doing well 15 years post-PCI, only on 3 pills. Apparently, the surgeon's excuse for losing all the grafts 1 week post-bypass was that at that time they were trying some new substance that they were wrapping the grafts with to stop bleeding. And it led to graft closure in almost all the cases they were trying it in. I have no idea if this was an approved clinical trial or not, but that's what happened to the patient. The situation of practice in Egypt and in India is complex because many of those patients are private patients, are in hospitals, are out-of-pocket paying patients, are patients who had been begging you for PCI, and yet you pushed them to do a bypass because it's the right thing to do. And then what happens is if they get a heart attack in the first week after bypass or incredible angina, and you have to go back and take them to perform PCI, especially like the last patient where you have to perform a complex complete revascularization of the, is very, very complex medico-legally. And those patients, again, in hospital, among the surgical community and the surgical intensive care unit in the early hours, are like a finely guarded secret. I mean, cardiologists, interventional cardiologists, are not called in commonly to the surgical intensive care unit. But surgeons do things, and they look, and they think of tamponades, and they like to take them back to the operating room. But we can actually save many of those patients, especially now with CT, by the way, because you can even do a CT and then decide whether you want to take them to the cath lab or not. So my conclusion is that starting immediately post-bypass, we are here to help. We are called the PCI standby as the surgical standby in our early days. PCI post-bypass is totally feasible, should be performed without delay, even if it's immediately after bypass. Technological advances with imaging and mechanical circulatory support improve our outcomes in those particularly vulnerable patients. And a PCI after bypass is actually not rare if you go for it and you tell them that you're there and you are not shying away from it. Of course, bypass after PCI is even commoner, and we collaborate, obviously, for the best for the cardiac patient. And this is the real heart team. Thank you.
Thank you very much. That's a very interesting concept that you proposed of a standby PCI for all cardiac surgeries. That's
yes.
Bypasses.
Yes, we should be standby.
Sasko, do you want to?
Great. I have one practical aspect about access. So you're still doing femoral for PCI?
Those 2 cases were done 15 years ago. And I have 15-year clinical follow-up. I actually have a presentation with 8 cases, which I present in cardiac surgery meetings, just to humble the surgeons a bit when we're in debates and things. But of course, here, because of the time, I just chose 2 cases. I'm an exclusive radialist since 2011, 100% radial, unless there is a prohibitive reason.
Great. You know, because it's very important, there are not so many aspects in international cardiology that are associated with mortality benefits. So we have mortality benefit not just in acute coronary syndrome, but in a chronic coronary artery disease with access.
Are you talking about radial?
Yes.
Absolutely. I mean, once you lose 1 patient for a retroperitoneal hematoma, you definitely, and many instances you don't even know why that happened. I mean, it's not like a high stick or anything. I mean, since we went radial, we don't see retros you know. And of course, but the whole trick about radial, though, is that you shouldn't be crazy about radial. I mean, if you go into radial and you find an arteria lusura, or you try to go to the lima from the right radial, I mean, there are some radialists who've shifted their focus from fixing coronaries to crossing radial obstacles. This is ridiculous. So you should have a low threshold either to move to the other radial or to the femoral. You know, so radial is good, but without being crazy about it.
We recently took one of our post-op patients same day for an angiogram again into the cath lab because the STs were up, the pressures were down. So we found an occluded lima. So the surgeons preferred to take the patient back to the OT, and they took out the thrombus in the lima and they revised the stitches. Probably the stitches were not good. And they said maybe angioplasty would not have been the best solution for this. The patient did well after that. So I think it could be either way.
Yes.
Some can be helped by PCIs, some are surgical problems,
yes,
which probably they help best.
I actually have also a significant number of angios of patients whose lima to LAD insertion was bad. And it's just one focal point. And you know, you can do anything about it. The surgeons talk about avulsion stuff, but fortunately I've never seen an avulsion. You know, you have to be gentle about it. You can either do it with a balloon or with a stent, and they do extremely well. And we don't, in those patients, we don't necessarily fix the native, because the very new lima is just an anastomosis stenosis.
Thank you very much, Hani. Please join us over here. And Sasko, would you like to invite?
Yes, next presentation is by Dr. Sarita Rao about navigating high-risk PCI in a young patient.
Respected chairpersons, ladies and gentlemen, a very warm good morning to everybody. Today I'm going to be speaking about navigating a high-risk PCI in a young patient with a disease that looks old. So we know that diabetes per se is a global health concern affecting young population due to the change in the lifestyle, the environmental, and the social fabric of our society. Cardiovascular disease, a leading cause of morbidity and mortality in diabetic patients, and people who are diabetic before the age of 40 have a 2 to 4-fold higher risk of CAD. And diabetes per se would increase the risk of MI by 4-folds in the young, especially when it's also associated with dyslipidemia, hypertension, and poor diabetes control. Diabetic cardiomyopathy and silent ischemia are also more prevalent in younger diabetics, and they commonly have triple vessel disease with severe LV dysfunction, now more commonly encountered in young onset diabetes. When we talk about the clinical presentation in this population, atypical or silent ischemia is also common, and they may present in many ways. They may present either as an acute coronary syndrome without any prior warning, they may present as a sudden cardiac death, or they may just come in with heart failure in their first presentation. And women often present later with more advanced disease. What about the anatomical and the angiographic features? Well, they tend to have more diffuse, calcified, and multivessel disease even in the younger age subset. They tend to have a higher incidence of left main proximal LAD involvement. The caliber of the vessels is typically much smaller. They have a tendency to restenosis post-thinning, and many a times they have poor collateral development in some patients. Now, recently, I did this case about 10 days ago, and we recently encountered such a dilemma. This is a 36-year-old gentleman. He's diabetic for the last 5 years that he knows of. He came to us with history of shortness of breath, class 3 for the last 1 month. He had a history of being admitted in Delhi with jaundice and shortness of breath in the last month. The jaundice was due to the congestive cardiac failure RV dysfunction. His echo done there had revealed an ejection fraction of 10%, global STT changes. He underwent an angiogram at a center in Delhi, which revealed critical triple vessel disease. On admission, his blood pressure was 80/60, there were basal Krebs. His sugars were 450. So this was his discharge summary, which he came with. His EF was about 10%. His angiography had been done on 24th of June, which had revealed an LAD lesion of about 90-95%. D1 was a CTO. Circumflex was also total occlusion with the bridging collateral. The RCA was a proximal total occlusion. When you look at his syntax score, you know that the PCI 4-year mortality is much higher. The CABG 4-year mortality was 1.2, and the obvious choice was the CABG. His SPECT had been done, and the scan findings were in favor of a complete thickness scar with no viable tissue in the inferior wall and normal viable myocardium in the rest of the segments of the left side. Now, the problem, young patient, very symptomatic, diabetic, very poor LV function, poor arteries, and a scarred RCA territory. What is going to be the long-term outcome of the PCI? And we're looking at what would be the short-term outcome, survival in a CABG, because his AF is only 10%. Would he come out of the pump? And on the other hand, there's a very calcific PCI, lesion in the circumflex. Are we going to be able to open it with a PCI? Should I give him the benefit of an IABP low-dose inotropes and see for some time if his EF improves, and then proceed for a CABG? The scores, how do they tell us? What do they guide us? So how to proceed? Should we go for a CABG or should we go for a multivessel PCI? What kind of MCS support should we use? What do the scores tell us? So we had a heart team discussion. Diabetic, triple vessel disease, young, EF only 10%, decompensated, mild RV dysfunction, very high risk for CABG as per the heart team, and the decision to proceed for a PCI was taken with impeller support. Though the guidelines are for a CABG with this kind of disease, but this was an individualized decision, it was decided to proceed for MCS-assisted high-risk PCI. Now, it is typically this patient population with a very poor ventricular function, extensive multivessel coronary artery disease, and working on arteries that are actually subtending a very large amount of viable myocardium. That's the kind of characteristics that define these patients, where hemodynamic support is indicated. So bad arteries, bad ventricle, you need upfront good support, and that's where the MCS came into play in this high-risk PCI. So we went ahead with upfront impeller insertion, and we proceeded with the PCI. In this case, why it was the choice? Because when you look at the York Health Economics Consortium, and you look at the data from the PROTECT 2, 3, and the RESTORE EF, to explore the hypothesis that using a percutaneous LVAD during high-risk PCI helps us to achieve more complete revascularization as compared to with an IABP. And results have shown a 40% greater reduction of residual syntax score post-PCI in patients treated with an impeller as compared to an IABP. So this is how we went about the case. Upfront insertion of the impeller. The RCA was a CTO, but it was a scarred, non-viable territory. This was the LAD-D1 lesion. And you can see the very tight lesion in the LAD, and the D1 is a CTO. The circumflex, there's a huge amount of calcium over there. We went ahead with first opening the diagonal. We needed to use a microcatheter support. It was opened up with a Gaia 2. We prepared the bed with a cutting balloon preparation finally, and then we went ahead with the drug-eluting balloon, and this was the final D1 with no flow-limiting dissection. Subsequently, we went ahead, used the non-compliant and cutting in the LAD, opened it up, used a 3x34 DES, and this was the result of the LAD D1. Now after that, we went into the LCX CTO, and we were not being able to cross with anything. So we changed multiple wires. The Gaia didn't cross, the Miracle didn't cross. Finally, after struggling for a long time, the Pilot 150 crossed over the microcatheter. A 1x5 balloon would not cross. The telescope was taken for support. We were still not being able to cross. So we attempted granuloplasty. At this point, I really wanted to take a rotor in, but the microcatheter would not cross. So we couldn't take the rotor wire in. After struggling so long, I didn't think I could upfront wire it with a wiper wire either. So we finally went ahead and attempted granuloplasty in this case, 1x5 still not crossing. So multiple balloons were taken for that. Lesion still looks the same. Some success after 4 balloons were ruptured, and then the 1O balloon crossed, serial dilatation was done, followed by stenting. Finally, the 2.522 DS crosses, and we were able to stent it at last. Post-dilatation done, and this was the final result for the patient. So young onset diabetes, bad LV function, bad arteries, that is an ordeal to manage. The patient is diabetic, severe LV dysfunction, triple vessel disease, class 1 for a cabbage. When you add RV dysfunction and an EF of 10%, the risk again tilts in favor of MCS-assisted high-risk PCI. Complete revasc is very important, and the tolerance of a very prolonged procedure is important. And we were able to open 2 CTOs, and the patient tolerated the prolonged procedure pretty well, and that was because of the support which we had taken up front. Chronologically, this is a young patient, but biologically, he has an aged cardiovascular system. That is the downside of young onset diabetes. Early intervention in such patients would offer long-term benefits in terms of the years of life gain, not just the MACE reduction. But it requires multidisciplinary care and close follow-up. So young hearts and old disease, early intervention is the key. Ladies and gentlemen, thank you so much.
Thank you very much. Great, great presentation, great case. So what is your approach for secondary prevention? So it seems that in this young patient it's very important to prevent evolution of coronary disease and diabetes as well.
So you mean to say that after the procedure, what would you like to do for the patient? Well, typically, I think this patient ended up where he did because he had young onset diabetes and very poor control of the diabetes. So one is definitely an aggressive control of his diabetes. Second, we put him on a DAPT and a high-dose statin, and he comes in for repeated checks so as to keep a proper control of his lipids level, his diabetes control, and his lifestyle.
Since with the PCSK9s and GLP agonists, I think we have much improved our availability to stop progression of disease.
I fully agree. But you know, in India, the pattern of dyslipidemia which we have, in India typically we have high TGs and lower LDL levels. So this patient's LDL level on 40 milligram of rosuvastatin was about 40. So in Indian population, that's our genetic makeup. Our LDL levels are typically not so high. So he did okay with 40 milligram of rosuvastatin.
Insulin resistance is more of a problem in Indians, and high triglycerides is one of the common factors. So,
Sarita, beautifully done case. Just one point, I was thinking, now LED obviously was openable, circ was CTO. The sequence, you know, normally if we open the LED and then fail in circumflex with all the impel and everything, so CTO doesn't cross. So that point obviously is in our back of mind that we can try LCX first as a sequence number 1, and if we open it, LED can always be dealt with. That just came into my mind.
So that's a very interesting thing because, you know, in this patient, up front when we had the heart team discussion and the discussion with the family, they were very clear. They were not ready to take the risk of a cabbage. And I had told them that my chances of success in the LCX CTO, I would have a failure rate of 10-15%. In spite of that, they were very clear. Now, my LAD was the single surviving vessel. And I had to secure that right at the onset because I was prepared this is going to be a prolonged procedure. So we went ahead, fixed the LAD because we wanted some flow at least in one vessel. The patient had asystole 3 times during the procedure, and it was the impeller which saved him. So we wanted at least one vessel flowing. So both the hypothesis is great because many a times we do that if we can't open the CTO, we send the patient for a cabbage because we're not succeeding with the CTO. But in this case, we were very clear. There is no way this patient is going to go for a cabbage.
Dr. Rao, thank you. Again, amazing case and amazing skills and a great save. Two quick questions. The first one, this is a very young patient and the circumflex is non-dominant. It's probably a good idea, in spite of any data on viability, to open up this RCA at an elective procedure, because you don't really want this patient to be living with just the left system. Even if the RCA territory is not viable. I mean, we know from the long follow-up of complete revascularization, it's almost always better, and also even as a collateral conduit in case something happens to the left system. So are you thinking of bringing this patient back and doing the RCA is my question. And the other quick one is related to Sasko's question about secondary prevention. We've heard that LP little a is elevated in India, and we don't even know the normals in the Indian subcontinent. So is there any work being done on LP little a, and because that, again, would be an indication at this point in time for a PCSK9, regardless of the LDL level, and then till specific drugs come?
Great questions, Dr. Henney. So your first question about the RCA. Now, at the index procedure, why we didn't touch it? Because there was no viability, and also there was evidence of scar tissue. But your point that if I open up the right cyste at a stage procedure, it might give off collaterals to the left system, and in case something happens to the left system, the patient would still be okay, is a great point, worth taking and worth attempting. Interestingly, this patient has just come back on follow-up. We looked at it LV, and from 10, it's jumped to 35%. So yes, maybe later on, we might think of doing it for the reason that you said. Otherwise, it was a scarred, non-viable territory. At the time, I wasn't going to touch it. Your second point about lipoprotein A, yes, that is a very important thing currently. And if you look at the studies in Denmark, they've shown that there's almost a 4 to 5 times increased risk in CVD for people who have an elevated levels much greater than 50. The interesting part is that the drug which they use for it, the pilacarsen, is not yet available in India. It's going to be launched, I believe, after a year, but currently not available. A lot of people are actually looking at the lipoprotein A and trying to correlate it to the CV risk, even at my center. We're now sending it routinely for all patients. But what we are seeing is that the Indian population, the incidence of a very high LPA is not so much, but in those patients who have had a very aggressive disease, we are finding cases in which the levels are higher. So that's interesting. Currently on the shelf in India, all that you have is inclisiran, because in some cases, they've reported that there's almost a 30 to 35% reduction in the levels using inclisiran. But pilacarsen per se, not available in India.
Thank you very much, Sarita. So we'll move forward
Thank
now
you.
to the next session. I'll thank all the moderators and chairpersons for this session, and a big hand for all of them. Yeah. So we move to the next session, and let me invite Dr. Prashant Kaul, Dr. Sanjog Kalra, Dr. Pratap Kumar, and then Dr. Rustam Datov, Dr. Vishal Rastogi, Dr. Richa Sharma, Dr. Himanshu Gupta, Dr. Gajendra Kaller, Dr. Raman Chawla, Dr. Rajesh Jindal, Dr. H.R. Tomar, Harpreet Singh Gilotra, and Dr. Lalan Jha. Hi, Sanjog, you got to catch a flight? We're starting off with you. So we'll start with the first presentation from Dr. Sanjog Kalra. He's going to tell us about IVUS-guided ostial nailing.
Good morning, everyone. Thanks very much for the opportunity to be here. Let's power through this 8 minutes, and then maybe we can have some discussion around the technique. So, how does real-time osteal stenting provide value? Right? It's valuable in a variety of different anatomic subsets, the aortoosteal locations, and then, of course, bifurcations. The issue is we have to understand when this is an appropriate technique and when it's not an appropriate technique. So, it adds value in these sort of scenarios where you have fairly clear end of disease at true ostia. It adds value in these sort of scenarios where you have disease at the ostium of the circumflex. It's a dubious landing zone, or a landing zone with some degree of angulation where you can't quite tell whether or not this is a safe place to put a stent without significant protrusion into the point of confluence. And then, of course, it adds some value at the aorto-osteal locations where you really want to make sure that you have good strut coverage of the ostium, because generally speaking, the prep at the ostium is what determines your result. But where it doesn't add value is a situation like this, where you actually have disease that goes past or into the carina or crosses into the left main, because ultimately landing a stent towards the proximal part of the LAD comes with a serious downside in that you can dissect the plaque just proximal to that stenosis, and your failure rates end up being quite high. This is the other place it doesn't add, is when you try to nail a circumflex when in fact there's a bunch of disease going into the ostium of, or into the distal part of the left main. So what do we mean by an optimal landing zone? And to understand whether or not you can nail an ostium, you have to understand what it is that you're trying to achieve. So we can define the optimal landing zone plane of an area within 1 millimeter of the true ostium. So it has to be 1 millimeter outside of the vascular edge or right at the vascular edge. 1 millimeter inside the vascular edge becomes rather problematic because these are the classical patients who end up getting ballooned during the preparatory strategy, where you injure the endothelium at the ostium and then you end up getting an inflammatory response with in-stent restenosis right at the ostium of the vessel, and that's a particularly bad area because it means you are by definition doing a multi-centimeter or a multi-millimeter overlap when you bring that patient back to restent. So if this is the main goal, then what your main goal ends up being is adequate plaque coverage. So if your plaque ends just inside the ostium where there is a true ostium in which to land the proximal struts, that's a perfectly reasonable thing to do. The issue is what happens when there's plaque right up to the end of the ostium where you start discussing perhaps dropping your struts out by a half a millimeter or so. This is a perfectly reasonable thing. We all know this as interventional cardiologists. The problem becomes when you actually try to do this without careful management or careful direct real-time imaging. When you actually look at how often procedural miss occurs when we try to nail an ostium, just out of curiosity on the panel, out of 100 cases, how many times when we say we've nailed the ostium have we actually nailed the ostium on CCTA? Any thoughts? Number of times you've actually nailed it when you think you've nailed it?
At least about 70%?
13%.
Just 13%?
13%. 87% is geographic miss. So that's kind of scary, right? Where we see it on an angiogram, but we don't have the level of detail necessary to be able to suss out the fact that we do not have a landing within that 1 millimeter of the aorto-osteal segment. And that's really quite problematic. And so this is great work that was done by Sarah Farley and by Scott Harding. And what it does is develop an approach to understanding what an ostium is like, and therefore when it should be nailed and when we should be crossing over. So there are 3 failure rates or 3 procedural risk factors associated with failure at the aorto-osteal location, right? It's underexpansion, it's proximal stent overlap that I had mentioned, and then there's excessive stent protrusion, because what happens when we stick a guide near a stent that's excessively protruding? We destroy it, right? This is what October taught us relatively recently, where those who ended up getting longitudinal stent deformation at the ostium of the left main, if it wasn't treated, 25% of them had an event at the follow-up, right? So that's a truly, truly bad situation to be in. Now, when we talk about geographic miss, we've got to get a good idea of precisely what it is that we're talking about. There are different types of miss. There is procedural miss, that's us, right, where we put the stent. And then there is anatomic miss. That's a miss dependent on the patient's vessel angulation or the location of the disease. And there are cases in which this is an inappropriate technique because by definition you will end up in an anatomic miss type scenario, right? Where because of the angulation there is no way that you will be able to nail the ostium. And that means when you're going to select cases for this type of a technique, you actually have to select an appropriate one where you don't end up with extreme bifurcation angles, because those are the ones where your anatomic geographic miss ends up going up. And this is why. It's because of the way these angles are seen, right? Where by definition, you're going to have a variable number of struts, and you're only going to end up getting one end of the ostium. So for a stent sort of like this one, you're either here and this part is uncovered, or you're here and this part is jutting out into a left main carina, which can then get in the way when you're delivering things into the LAD, either during this procedure or further down. So if we take 100% of osteal PCIs and we mention that there's geographic miss in 87%, about 40% of those are procedure dependent. 60% are anatomic. And so it is that 40% where we can actually make a difference. Okay? That's where this technique works. And osteal stenting and bifurcation, for those that are anatomic miss, these are inappropriate. This is where you don't use this. So how does this done? First thing you need is a 7 French guide. The Cordis guides have a slightly smaller internal diameter. You need a .081. You need a 5 French rotational IVUS, and you need the stent shaft, obviously, on the wire. But what ends up happening then is the first thing you do is engage your guide, and you wire your 2 vessels. Okay, and then you prep them. And once you deliver the stent, you place it at what you think is the ostium. Okay, get yourself reasonably comfortable. Sometimes what I will do is push the stent further in so that I have a bit more room at the carina to be able to deliver things. The next thing then is you turn the IVUS on and you insert it. Okay, and then on the IVUS, you pull the IVUS back until you can visualize the ostium. And now when you come back and you're visualizing the ostium in the far field of your LAD, let's say the IVUS is in the circ, then you have to understand where your stents are. Because different stents are mounted on balloons differently, and so you can see proximal marker differently on an Abbott Zynes as you can see on a Boston Scientific Synergy, for example, where we know that the stent is actually located on the inside of the marker with Boston Scientific stents or with Medtronic stents versus in the mid-marker segment with Abbott stents. And so the proximal stent of the SDS, okay, the proximal part of the stent deployment system, the marker looks like a tight circular band. And so this is what you end up seeing in the far field. Then when you start seeing striations, ribs come back, that's when you're looking at the stent marker band. Okay, so you see the difference between this beginning, this is where you're starting to get into the marker band, right, where your IVUS lens is starting to get lined up. And then this is where you're at your first stent strut. So what you're looking for is to define the position of your first stent strut at the ostium of the vessel, so long as you're not in an anatomic miss type scenario. Okay, so this is what that looks like, where here's your IVUS, there is your lens, where you can see the far field, and now what you've done is pulled this back until you see the first strut here, recognizing that your goal is right at the ostium or within a 0.5 millimeter of the ostium. Okay, so that's what this looks like, right, where you're starting to see the very end of the marker band. If you see the start of the first strut, you've gone a little bit too far, you push it ever so slightly back in. And it's very important that you have a big enough guide because there is interaction between these things, right? So if you end up pulling the IVUS back slightly, you may change the position of the stent, which is why the order in which I recommend you do it is stent further in than you need, IVUS down, IVUS back to line up and visualize, stent back to the ostium, and then you recheck. Okay, and then that's what you can end up achieving when you actually do this technique as it's described by Sarah Farley and Scott Harding in their paper in CCI a couple of years ago. So for non-aortoosteal lesions, what you do is drop the wires down. You're able to visualize or fluoroscopically co-register, prepare, okay? And then ultimately a nice way of doing this, there's a variety of different ways. As you pull back, here you see that there is disease right to the level of the ostium and that this is the extra wire out in the circumflex. So this is the one where you put in the stent, you advance very first to the target, you bring the stent back to where you think you're going to need to be, you turn on your IVUS, you look at the IVUS lens and then pull back the stent so that the stent is barely seen on the IVUS where you're just looking at the marker band, okay? And that way you can start to position the proximal stent edge where you would like it to be. Okay, and you'll see on this IVUS here, there, right? So you see just the beginnings of the ribbing of the first struts, and that's where you end up deploying the stent. And then you retrieve your IVUS probe, and then you can post-dilate, so you walk away with the final result that looks pretty reasonable, but most importantly on IVUS is respectable. For aortoosteal lesions, it's a little different, where, let's take this RCA, okay? You put this wire down, you open up the right coronary, and you put a second wire into the aorta. So you now own the space. And this is useful in two respects, right? Because then when you advance the guide, you have something that keeps you outside of the ostium. Prepare the vessel, and then you put the IVUS in, You can mark the ostium so you understand precisely where the disease ends. So like in this case where the disease is actually ending at the true ostium of the vessel, right? There's the disease and there's where the ostium ends, okay? Put in the stent beyond the level of the ostium again. Drop your IVUS in so that you're able to see in the far field where the RCA ostium is. You put your stent is already in, you pull it back so it's visualized within the aorta where the stent frame, you're just starting to see at the points of the ostium, okay? Right here, right? You can start to see the stent edge and you can see that true ostial segment here. This actually I would pull back about another millimeter or so. And then you deploy. Withdraw your IVUS, post-dilate, and walk away with a respectable final result. This looks technically complicated, it's actually technically really easy. Right? There's not a whole lot of technical finagling that's necessary. And this is a slightly novel approach in the last moment where if you need to nail the ostium of a left main, you can actually do this through a 7 French guide or easier through an 8 French guide when what you're trying to do is define the precise location of the left main ostium. So in this case, you have 2 wires down, you put your IVUS catheter in, and you actually pull back the IVUS lens so that right on the IVUS you can see the ostium of the left main. And what I recommend at this point that you do is you take a small puff so that you fluoroscopically co-register the location of the IVUS lens, which itself has a width of about 2 millimeters, okay? And then you pull back the stent so that it precisely lines up with the IVUS lens, the edge of the stent. This is done on high-def fluoroscopy, like stent boost or something. And then when you see the ostium and you see the stent in precisely the same way you did before, you're able to relax the stent, right? So you don't deploy it here because the IVUS is right next to it. You relax the stent, you put it up to about 1 atmosphere so it doesn't move. Gently pull back the IVUS and then just deploy. And the nice thing is you can actually see the stent on the ostium of the vessel once you've deployed it. So with that, I'll stop, and thanks very much for your time and attention.
Sanjog, as usual, wonderful presentations. When you show these cases, actually, people will feel that it is all very easy to do, but it is not that easy.
Yeah.
I just wanted to ask you that after nailing with an IVUS, is it compulsory to do an IVUS again to reconfirm that arm?
This is an excellent point. I'm going to tip my hat to Himanshu here, who wrote a very important paper, which really nails down why it's so important to do the IVUS at the end, right? We know that there's a lot of potential energy stored within the connectors of stents. Right? Depends on the type of connector you have, but if you take, for example, a synergy where there's actually a little bump or a half moon in the middle of the connector between 2 cells, you have potential energy where that stent can elongate. And so if you then end up dilating from the distal end of the stent back to the proximal end, you will in fact elongate that stent. And if you read Himanshu's paper, you'll see that that stent elongation can be several millimeters, which will destroy any hope of you actually getting the result that you want. And so it is actually important to recognize that not only do you need to post-dilate from proximal to distal in these types of patients where you plant the proximal edge, but if you're worried about your distal landing zone, what you do is post-dilate the prox, you post-dilate the distal, you keep the potential energy in the middle so that it doesn't actually end up elongating in either direction, and then you do your secondary IVUS to make sure that you've actually achieved the result that you're trying to achieve. It is overwhelmingly important to do that. Thank you for bringing that up.
One doubt actually is, Joe, when you do post-dilate, do you think that there will be an elongation or a shortening of the stent can create moving away from the stent ostium?
So, Himanshu, do you want to take that? Because it's your paper.
Yeah, generally, if we post-dilate the stents with a larger balloon, the stent cells will open. And with the newer stent designs, all of the stents can accommodate almost 1 millimeter of dilatation. But when they dilate in both dimensions, longitudinally and also axially. So the stents elongate when we start dilating them with bigger balloons. So if we come from distal to proximal, the stents elongate, especially if there is malapposition at the proximal edge of the stent. Suppose there is a crossover stent from left main to LAD, or as we are nailing the ostium of the LAD with a long stent, we've sized according to the mid LAD, but the ostium of the LAD is bigger. So the stent will elongate once you post-dilate.
You will not miss the ostium then?
No, if anything, you'll get longer. You won't get shorter.
You won't miss, but it will come back.
Yeah.
And Sanjog, would you say that when we are nailing the ostium of the LAD with live IVUS, it works more predictably when the angle is wide between the circumflex and LAD?
The ideal scenario is where you can clearly see the ostium of the LAD in the far field, right? So there's a balance, right? Those of us who do CTO PCI, when you do things like IVUS guided proximal cap puncture, you recognize that when the angle is too wide, you can't see the far field. And when it's too narrow, you're prone to anatomic miss. So the range of angles where this type of a technique will work well will be sort of a bifurcation angle of between, sort of 60 and maybe 95 or 100. Outside of those angles, you're sort of prone to anatomic miss.
Because we discussed this with Scott also, who originally published this. And he said that whenever we do it, we've done it a bunch of times. When the angle is very narrow, it is very difficult to nail the ostium even with IVUS.
Correct.
So it needs a perfect angle for it to work.
Yeah, the extremes, if you look at a normal distribution curve, this is a useful technique for sort of the middle degrees of angulation, where on either extreme it's not going to work very well. But, I mean, the beauty is that crossing over from an LAD to a left main with IVUS guidance and good post-dilatation is a pretty safe thing to do, right? And so I think that this is a really nice technique in the correctly selected patient. But if there's no need to kind of get fancy, don't get fancy. You just cross over and do a good stent dilatation across from the LAD back into the left main.
Thank you so much, Sanjog. And while Prashant, we invite the next speaker, that is Dr. Pratap Kumar.
Yeah, so
one last comment from Dr. Vishal.
Yeah, my comment, Sanjog, is that you've enumerated all the ways how to not stent failure should not occur. But then one of the important factor is that we do not dilate the ostium well because we are worried about the destroying the landing position or carina. So once you are using IVUS, you should use it well to make sure that the bed is prepared well.
Respected chairpersons, I'll go to the case. Actually, I'll show you two failed CTOs, what have they learned. 75-year-old male patient with NSTEMI, December 2024, with an CKD stage 3, this was an angiogram. LAD ostial 100%, OM 90%, RCA 100%, distally filling by homocollaterals and reticularly filling LAD. So this was the situation. So patient is actually having an LAD CTO, RCA CTO. The plan was to do LAD CTO PCI, PCI to OM and PCI to RCA CTO. Antegrade approach to LAD and antegrade or retrograde approach to RCA. So we decided to stent first the only vessel which is easy to do as an OM. I did that. Then we decided, I tried an epicardial collateral because actually looking like very easy access, but I decided not to continue with retrograde because it actually failed miserably. Then I tried antegrade again. If you look at that, I used an AL1 Caravel filter FC wire, choice, and then took an anchor and guide extension. I used a trap liner. Even with the trap liner, I wanted to show that with the trap liner again, the wire was there, but the wire is crossing, but it was taken a filter. Subsequently, I changed to Guyanex 3, UB3, Congress Pro 12, all going outside. So there is no way out. So why I failed? Its length was more than 20 millimeters, tortuous, ending in bifurcation. So always, whenever you end in a bifurcation, distal RCA stenting or distal PDA PLV junction, the continuous bend, corkscrew, this is actually the point where I failed retrograde collateral. That is actually epicardial collateral I failed because of that. So J channel score is more than 3, the failure chance is nearly, success stands only 40%. How could I have done better? Parallel wire, dual lumen catheter, Gladius ES, Miracle Neo which is not available, Stingray, tip directed ADR. All these are possible things. Then I went directly to the LAD where I crossed filter FC with the Caravel. I went, crossed, then I used a 3.5 into 38 stent, 4 into 12 balloon, post dilated. I left that case again. After 1.5 months, the same patient, you can see that there is an excellent collateral coming up. So I did not go antegrade here. I tried 2 collateral channels where it's a more straighter but fainter, starts at a standard segment. This is actually first collateral. Second collateral is a CC2 collateral which is actually tortuous but entry is very easy. But you can see the tortuous in the distal part. I tried that. Caravel with a filter FC wire. Then I changed to SUHO3 wire. You can see the SUHO3 is bending down because of the tortuosity down. I pushed, landed in problem, created small dissection. Then I went into the first channel, which is through the stent strut. Same caravel, but here with the cyan blue, plain cyan wire, I went directly to the PLV distal part. Here, fine cross, then FILREF-C fine cross. I changed to fine cross after the caravel. Guy-Nex3 retrograde. I went UB3 retrograde, Infiltrac plus antegrade combination. Lot of work, both the channels, reverse cut with 2x12, Guy-Nex3 retrograde, guide liner, then balloon trapping, RG3 wire crossed. By the time I saw that there is a septal leak, you can see with the first channel I created, you can see there is this channel leak I created because of the, you used an nub-gel, you could have used a coil also there. Final result like this. This is the first failed and CTO with RCA opened up next time. This is a 57-year-old women patient, actually non-smoker. According to the patient, she admitted July for angina on exertion, underwent CAG followed by PCI. This was an angiogram. On 15/7, LED ostial CTO, RCA is filling. You can see this one. You have an ostial lesion, which is actually very tight, even ostial LMCA. There is a circ osteoproximal is tight. Then the operator first have done a right radial route, AV3 to LMCA. They put a BMW wire to the circumflex, FILREF-C to the fine cross, to the out of the vessel. It is totally out of the vessel LED. If you look at that, wire is totally out of the vessel. From the ostium, wire is not in the lumen. He tried retrograde. The wire went somewhere without even an injection. He just surfing only. You can see the wire moving here and there. They used a SUHO3 wire, then decided to leave it. Not only that, he did a 3.5x12 stent in the proximal circumflex. Because of the fear created, he put a 4x8 stent in LMCA. So the LED is not done, but this was the case. Patient came to me. So the things missing in this case are no clear understanding of the anatomy. He did not use a parallel wire technique. Antegrade wire escalation was not done properly. But positive things in this case was dual injection was done to understand, and there is a safety wire in the circumflex. But the pros patient saved and not dissected the LMCA and kept for the second time. What are the cons? By keeping a stent in the LMCA, the second attempt becomes so tough, and it's a very short LMCA. So after 10 weeks, this was the time I got the patient. 7 French EBU 3.5 and 7 French JR 3.5. What I did is, I started with a FILREF-C and fine cross. I saw an excellent channel, but my wire gone easily through the excellent channel into the LED, through the septal collateral. Even I did not take any other wire, just with the FILREF-C itself, it is gone. But that was an angle, so I could have to manipulate my fine cross into the proximal LED. FILREF-C wire into the circumflex with a safety, because otherwise I will be in trouble. So I took an IVUS to understand the entry point, but I was not able to understand. Then I not able to see the origin of the LED. By IVUS in the circumflex also I could not identify, because of the angle was too tough. Then I tried an antegrade because I wanted to do a reverse cut to get in. A Gaia 2 wire retrograde, not crossing. Balloon 2.5 into 12 dilate LMs to circumflex to understand the entry point, but the wire is only going into the circumflex. I push the fine cross into the LMCA and nothing happens. You can see that the wire, actually the fine cross came into the LMCA through the stent strut outside. Then I decided exchange with the UB3 wire. Again, I am not in the right place. The wire is outside. Then other options are guidezilla and snaring. Guidezilla will not work out because it will only go to the circumflex. Cyan black wire changed UB3 into the retrograde wire. This is actually the guidezilla. I thought I'll keep the guidezilla in the osteoproximal part of the LMCA. Because of the stent, nothing worked out. Then I decided to snare it. Snare the guide wire to the EBU catheter. So once I took the wire into the snare, actually this I snared. After snaring, I took the catheter inside. I balloon trap with a 3.5 millimeter balloon. Cyan black wire is exchanged and then to RG3. After the RG3, I was in the RG3 wire. I tried after balloon dilatation. Then I was catheter pushed into the mid LAD. To understand that, I was LAD post retrograde wire crossing. What I have seen is there is a true lumen to the false lumen and distal to the proximal. So there is a false lumen in the osteoproximal part and with a calcium nodule in the part. So the false lumen to the true lumen in the osteal LAD, but I am saving with a stent in the circumflex, LM to circumflex. Then I balloon dilated. We used a cutting balloon in the osteoproximal part because there is a calcium nodule was there. 3.5 into 12 in the osteoproximal part. Then the 3 into 38 stent LM to LAD, LMCA to LAD, and a 3.5 into 12 balloon LM to circumflex. We did an IVUS again into the LAD post IVUS run. LAD was underexpanded in the proximal part. Strut across the side branch. That is actually, there is across the side branch you can see the strut. We shifted the wire to cyan black because I wanted to enter to the distal LAD. Now still I am not in the distal LAD. 3.5 into 12. I was in LAD again. We got an LAD distal part 5.76, but you can see that this some part is totally underexpanded in the middle part. I could not understand that. I used a 3 into 12, 2.75 into 6 balloon, cutting balloon, and I was catheter again because I was not happy in the proximal LAD which is not opened up very well. Put a stent distally, opened up LAD, middle part. I did an OCT to understand, but the IVUS imaging, I could not identify the proximal part. What I have found out, you can see that the middle part is totally underexpanded. That is a part. There is a nodule there, calcium nodule. MSA is only 2.39 post-run. So what I did is, I used the OPN balloon there, 2.5 into 10 OPN at 30, then 2.5 into 10 OPN at 45 atmosphere, opened up. Then again I did an OCT. Then we got a result like this. Even now, that area is not very big. We got osteoproximal LAD is very good, and the circumflex part is okay. There is a final result. Thank you very much.
So one comment, anybody? So it's an excellent case. So Sanjog, you wanted to make that comment? Yeah.
It was a nice case. It was a nice series of sort of problems solved. We were just chatting. I think I saw that you had come retrograde from the right and then externalized. And then when you were ballooning, you had sort of a wire down into the mid-LAD, but you still had your externalized wire. Do you typically leave your retrograde gear in? When do you sort of flip antegrade and get out? Rustam is a tip-in guy, right? Where when he comes retrograde, he will typically tip into the antegrade antegrade microcatheter and just come down and then swap out for a secondary wire. I'm more of an externalization guy where I like the externalized wire as a little bit more support, but I will flip to an antegrade system and get rid of my retrograde system sort of sooner rather than later. You can let your ACTs drop, get rid of one guide, reduce the hemodynamic load, blah, blah, blah. What's your approach?
There are two things. Actually, you can work on the retrograde system and the osteoproximal part. Subsequently, I shifted to the retrograde, the cyan black wire into the distal LED. Or you can take another microcatheter into the proximal part of the LED and remove that part and then push the wire into the retrograde. That is actually, these are the two ways, only because I was not very comfortable in the osteoproximal part, dissected segment. If I try something to do there, again a microcatheter pushing there, I was not very happy there. Usual practice is actually in this case, if there was no stent strut there, my practice is taken another microcatheter, go into the proximal part, remove this part and keep that microcatheter in the osteoproximal part of the LED, distal to the CTO segment, push the wire into the proximal distal LED finish.
I guess the follow-up to that for those who are in the audience who do retrograde and are learning their skill sets is this is where your collateral selection becomes very important. Where if you select a collateral that comes in very close to the distal cap, the likelihood of you causing vessel injury and dissection at the level of the distal cap goes up, which makes it harder for you to flip antegrade because when you come back down your externalized wire and then you try to rewire, you are at higher risk of getting caught behind the dissection plane that you've created when you're coming up retrograde. And so one wants to select a collateral if possible that has a little bit of running room distal to the
Sanjog, actually the first operator selected the same collateral, but he was not taken a proper
no doubt.
moving of wire. And the second time what I did is, I had never had a problem of taking the wire up and taking the wire out. Only thing is the stent strut was creating all the problem and nothing was coming out.
Yeah, I wasn't referring specifically to your case, but just as a general piece of advice.
Thank you for sharing.
Thank you, Dr. Pratap Kumar. We will now invite Dr. Antonio Colombo with my worst nightmare case.
Thank you very much. The main message of this case is that you can make one mistake, but is a second mistake that really puts you into big troubles. So every time you have a complication before taking the solution, really think very deeply what to do because you cannot make two sequential mistakes. This is a 78-year-old lady scheduled for AAA percutaneous graft. Patient underwent elective coronary angiogram, right radial for history of atypical chest pain, questionable indication, risk factors, hypertension. This is the first injection. So while the patient is second injection, the patient is asymptomatic, feels fine, no ECG changes. I go back to the first injection and I pause a second and I ask you why the patient is asymptomatic and why there are no ECG changes. The answer is not only useful for knowledge seeking, but is very important to establish the treatment. Because if you get the correct answer, you will get the correct treatment. Otherwise, you make sequential mistakes, as you will see very soon. Anybody wants to?
We are in false lumen, means we are in complete false lumen.
It's aortic aneurysm already, so
I didn't hear.
Probably it's aortic aneurysm already, so probably we are in the false lumen and injecting from that into the coronaries, and patient is that's why asymptomatic.
I don't think it is in the false lumen because you are seeing both the vessels very properly. I don't think it is in the false lumen. Dissection is there.
So still
LM dissected.
Yeah, the right coronary will come, but I think, as was pointed out correctly, we are injecting in the false lumen. and you see that there is a late filling of
Yes.
the
LED,
which is from the true lumen, and sufficient blood is going from in the true lumen. So these should have been the immediate assessment. Most probably, you could have even do nothing because I think this dissection will heal by itself. But unfortunately, we did not react in that fashion. The right coronary artery, I don't have the film, but is fine, and there is no collaterals going to the left. So that is an additional point that tells you that the blood is going from the true lumen into the left system and seems to be adequate, at least when the patient is at rest. So this is the first mistake. We took a guiding catheter, we reacted with the hypothalamus and not with the cortex. A guide wire was inserted and the floppy wire was advanced in the LED, not the knuckle wire, which basically tells you that you are going into the fourth lumen and you are making the dissection much important and going to the apex. Inflated a balloon in the LED, and after the balloon, the LED seems to be open, but is a dream opening. The circumflex is not visible, and believe it or not, I think the true lumen is still patent because blood is going into circumflex, and the patient is still asymptomatic. No ECG changes. So at this point, a third mistake, because here we go sequential, the operator placed a stent in the LED. So this is the final solution, because the stent now plaster the true lumen and basically occluded the true lumen. And here we have the diagnosis, but it's a late diagnosis because now the patient becomes symptomatic and there is a ST elevation and problems start. So at this point we are in real deep trouble because the blood pressure goes down, and I don't know what's happening here, but deployed even another stent, and the situation does not improve. I cannot say that it gets worse because it's already very bad. So despite the aneurysm in the aorta, a balloon pump is inserted. You see that the wire is moving very minimally, and the ejection fraction is minimal. The patient arrested. So the operator attempted stars. Subintimal was able to open the diagonal, and this time the diagonal was enough to re-establish some cardiac motion. You see that the wire moves a little bit better. No stents anymore. No, a long stent in the diagonal. And then a subintimal tracking was done in the circumflex, dissecting the circumflex and establishing the flow in the circumflex. And there is some recovery of the function. You see that the wire now moves. So basically this is a rescue extensive subintimal dissection which was impossible to recuperate the true lumen, but at the end all vessels became reasonably patent. 3 days follow-up, there is a compromise of the distal circumflex, but the LED is still open, the diagonal as well. Patient had a long recovery the balloon pump was removed right after the end of the procedure due to leg ischemia. The patient suffered distal leg embolization, which required multiple endovascular procedure with the need to perform a transmetacarpal amputation. Patient developed renal and respiratory failure, requiring prolonged intubation, hemofiltration, and finally patient became fully ambulatory and discharged 4 months after the procedure. At 3 years follow-up, she is stable, self-sufficient, and the AAA is still there. So thank you very much for your attention.
Sir, actually it was done in 2010, right?
Yeah.
So if you do the same case, if somebody else is doing this case now, what will be our approaches?
I mean, when you have a problem, unless you have a real impending emergency, the patient arrest, but even if the patient arrest is fundamental to make the diagnosis. As the first year in clinical medicine, no therapy should be attempted unless you make the diagnosis. So first diagnosis, then therapy. Here we establish the therapy without having made a correct diagnosis. So this is basically clinical medicine, no interventional cardiology.
No, the first instance actually when you saw that dissected segment, the wire was distally in the true lumen. Actually now if you do that, we can take a double lumen catheter and keep that pierce and penetrate from the subintimal to the intimal and entry almost at the proximal part without losing the septal collateral. That is number one. Number two, even the first instance, the circumflex was more having a lot of subintimal space, but you have a minimal flow through the some true lumen into the LED was there. We could have kept the wire there and take another wire also probably would have helped us.
No, but I think the correct approach would be to leave the catheter into the fourth lumen, go with the guiding catheter parallel, and the entrance in the true lumen would have been very easy because it was very big, and place a short stent at the ostium of the left main, 15 millimeter stent, that's it. So, very short stent at the ostium of the left main would have blocked. If anything, you could even done nothing, just finish the case, because the flow would have occluded the fourth lumen, and the patient would be fine. So I think we converted a relatively lucky complication into a very bad one.
An imaging, like an IVUS, would have given the answer, no? The very first injection, when you were not sure whether it's true, false, etc., etc. Just an imaging would have told you where we are in terms of the anatomy. Sort of LAD into the left main.
Yes, but you know, IVUS would be okay, but I think if you just use your brain, you knew what was going on. The diagnosis was really very simple. Just stop a little bit, go and take a coffee and come back and think why this patient is stable, look at the angiogram again, and you get the diagnosis.
Yes,
I think
the main
again,
message.
We reacted with the lower brain and not with the cortex.
Yes, so the main message is very loud and clear. And you have a lot of technology, but nothing can replace what you have over here.
Nothing can. You just need, you could even stop the case here and use your brain and make the diagnosis. Case is finished. You go home and...
Anandaraman, the message actually, but he is telling that we should not do therapy before diagnosis, but actually techniques now Japanese adopt is actually a tip-directed ADR is actually the one technique where we can actually pierce the wire and go inside, but that also then we will lose the septal artery.
Yeah. Last comment, Prashant?
So just to sort of take a step back, do you think that, was this just a guide-induced dissection to begin with, or do you think this was a SCAD situation?
No, this was the, if you see the first injection, can I go back? Is there any way I can go back to the...
Sorry?
Please restart the presentation.
Can you put on the presentation again?
Yeah, okay. Here, you see, we do these frequently, but you see that the catheter is pointing up. We do it all the time. We take it for granted, but it's not a good way to position. 99% of the time, nothing happens. But in this case, first of all, the catheter was not positioned correctly. And this is what created the problem. But again, the message is that we have all the technologies, but there is no substitute for making the right diagnosis. And many times you don't need technology, you just need brain reasoning, and do not react immediately, unless there is an absolutely need to do that.
Thank you very much, Dr. Colombo. A big hand for this, such an insightful case. Prashant, would you please step up to take the next presentation? Thank you.
Thank you, everyone. Good morning to you all. You know, the title of Dr. Colombo's talk was My Worst Nightmare, and I'm not sure I can imagine a more nightmarish situation than that, so that was pretty impressive. But, you know, if you do complex cases long enough, you know, you will see situations like this, and you will see complications. It's not a matter of if, it's just when. And so, continuing with that theme, you know, I was asked to just speak a little bit about device embolization. And so, you know, this is something that hopefully you'll never see, but it's a good chance you will. And so here is just some sort of an overview of how to handle these types of things. So I'm going to talk about stents, catheter tips, and wires. Fortunately, it doesn't happen very frequently. The true incidence is unknown, but it's probably less than 0.5%. And there are the obvious risks of thrombosis, dissection, embolization, and so on. So this is what not to do. You know, really the main thing is to just remain calm. Like, as you've seen in this last case and all of these cases, the first step is to sort of go through some problem solving and have a mindset in sort of to do that. And just because you've made one mistake, it doesn't mandate that you make another one. So that should be the sort of idea that, you know, let's sort of think about what we're doing first. So let's talk about stents first. So, you know, if you've lost a stent, the first option is to retrieve. You can sometimes deploy the stent, and then as a third option, you can try and crush the stent. So in terms of retrieval, if the lost stent is still on the guide wire, you can take a small balloon through distal to the stent, inflate it, and then pull back. The other option is then to use a snare. You can take gooseneck snares, a pedal snare, again if the stent is still on the wire. And then there's also a technique of using a multiple guide wires to sort of wrap the stent and then pull out, and that is also effective sometimes. In addition to that, you can also take a guide extension alongside and then trap the stent against the inside of the guide extension and then pull the whole system out. And then as a last resort, some have also suggested using biotomes or forceps, but this typically isn't necessary. So here's a case just to sort of show a few of these techniques. So there's a recently freshly placed stent in the ostium of the LAD that comes out, and then there was a lesion in that high marginal branch that was prepared with a balloon, and then the next step was to put a stent in. But as the stent was advanced past the ostium of the LAD, it snagged the stent, and now you can see in the left main the stent has stripped off the balloon. So in this situation, what was done, you can see here's just another view, and rather than, it was a 2.5 stent, and it's a large size left main, we didn't want to deploy it there, so we took a balloon distal to the stent, and then pulled inflated the balloon, and then pulled the stent in towards the guide. The problem we had next was that the stent then flared a little bit as it was entering the mouth of the guide, and we then had, it wouldn't enter into the guide, so we had to pull the whole system back down the arm. And as we continued to do this, the next problem we had was that it wouldn't come in through the sheath. So now the stent had flared so much that it was larger than the 5/6 sheath that we had in the arm. So we left that stent system there for a moment. We then got alternative access, put a guide extension beyond the ostium of the LAD, finished the stenting procedure so that we were done with the PCI, and then came back to solving this problem. So what we ended up having to do was upsize the sheath in the wrist, and then we took a snare and then snared the whole thing through the larger sheath, and then we were finally able to bring the stent, the severely distorted stent, out of the arm. A check angiogram of the radial looked fine, and this was the retrieval of the stent. So obviously it wasn't as easy as just putting a balloon through the stent and then pulling everything out. Along the way, there are a number of issues that you have to, a number of problems that you have to solve, and so it's important to do that and be able to do that sort of on your feet in real time. Now, you can also deploy the stent. Certainly if you've if the lost stent is not on the guide wire, you can parallel rewire and then balloon and stent, and then you're just left with crushing the stent. And so here's another case. This was a 75-year-old woman, 2-vessel cabbage previously. There was bioprosthetic AV stenosis, and there's a plan for valve-and-valve transfemoral TAVR. And here was some snorkel stents that were placed, but somehow these got dislodged. And so now there's a stent not on a wire in the middle of the RCA. And so this was just, there was another stent placed alongside it, and the stent was just crushed. And so this is probably the quickest way to deal with this problem, and there were no long-term outcomes. So the next thing that I wanted to just discuss briefly are just catheter tips and balloons. These can often break off. So here's a 70-year-old male. He's had previous 4-vessel bypass, presented with an acute coronary syndrome. The grafts were patent, and he was found to have this lesion in the proximal RCA. This was not bypassed at the time of the initial bypass surgery, and so we had difficulty wiring this vessel. We used an anchor balloon in that conus branch, and then we used a caravel to try and get we had a wire. Now we were planning to switch out for a rotofloppy. This is a caravel, and the caravel would not cross beyond this lesion. And so now what happened, it wouldn't go further, it wouldn't go back. We tried pulling it back, and the tip of the caravel catheter broke off in this lesion. So the shaft of the caravel is now out of the body. We have a wire down, but the tip, the plastic tip of the caravel is lodged inside this lesion. So what we did here is to take a guide extension and then a 2.0 balloon. And we took the 2.0 balloon and just advanced it, and it went into, it was both the caravel tip and this balloon obviously are on the same wire. We put the balloon into the tip, and then we were lucky enough that this tip got lodged into the balloon. And then we pulled the balloon back, all the way back in, and you can see in the bottom left, in this picture here, the tip of this caravel has become lodged into the balloon that we've just taken. So then the piece, now you can see it separated, we were able to procure back. But you know, if you haven't kind of seen this, you may not think that this is an option. So I kind of stumbled upon this just by chance, but you know, I've had one other situation where I've tried to do something similar and it's worked. So just know that in a situation like that, you might be able to retrieve catheter tips like that. And so then we were able to then free wire it, rotor, balloon, and then we got a nice final result there after having retrieved the tip of the caravel. So here's another situation. This is an underexpanded stent. We went in with laser. And what you see here now is the radio-opaque ring of the laser has now detached from the laser itself. So there was some issue, the stent was so underexpanded that it sort of grabbed onto the laser, it became stuck. We pulled the laser back, but the radio-opaque ring remained in the vessel. And so we did a very similar technique here, took a balloon distal, inflated it, and this time we were able to just pull the whole system back. And then we were able to, and you can see now the radio-opaque marker from the laser lodged onto the balloon. We were able then to use an OPN and get this expanded, and then this was that we were able to address that. What about if you have a wire trapped or fractured? This happens not infrequently, and the way to think about this is to understand whether the wire is still intact but trapped, or if the wire is fractured and half of the wire is now out of the body and you have the wire still remaining. The key piece is do not pull the wire. If the wire is still intact but trapped, don't pull the wire. That is because it's much harder to retrieve the wire if it's already fractured. So the best thing to do is to advance a microcatheter over the wire as far as it will go. That will give you the leverage, and most times the wire will then free itself. But if not, then you can try advancing a balloon over the wire, inflate that. You can try a guide extension, trap it with a balloon alongside it, and then bring it back. And then if the wire is trapped, then if the wire is trapped but fractured, you have some options to snare it and so on. Here's a case here I'll show you quickly. So this was a vein graft aneurysm that you can see, and one of my partners was putting a covered stent across the anastomosis, just beyond the anastomosis actually, to fix the aneurysmal segment. But in the process, what happened is that he had a wire fracture, and the distal wire, you can see it circled, it broke off, and now he's left with this distal wire there. So in this situation, what I did is to take a second wire, this is just a workhorse wire, and I brought it alongside this other trapped, the fragment of the wire that was there, and just spun the wire alongside it to trap the two wires together. And that was enough to retrieve the wire, and we were able to pull the wire out. Okay, so another useful technique, a very easy technique, a quick technique to try first. And we were able then to pull, we sort of entrapped both wires together, the fragment and the new wire, and then we're able to pull everything out, a poor man's snare, if you like. So I could talk about this for a little bit longer, but in the interest of time, I'll stop there, and happy to have any discussion or answer any questions. But thank you very much.
Prashant, it was good cases and you are showing. But in Caravel, one important thing is in a calcified CTO, that's one microcatheter better not to take, because this is one catheter will be broken inside a calcified CTO. So preferably to take Corsair Pro XS, and I will usually take fine cross because that is more safe. But in India now Turnpike is available. So Turnpike, Spiral and Gold are very good microcatheters, but Caravel is one catheter.
Yes, so it's actually for this reason that we no longer have the Caravel on our shelf. We don't even stock the Caravel anymore. We
use actually for the retrograde CTO intervention, especially for the collateral connection and the collateral injection, the better visualized any microcatheter is Caravel.
Yeah, this case was some years ago when it was during our initial experience with Caravel.
Change our strategies.
So after that, we stopped using it, and in fact, we have the whole Turnpike family. So my usual initial catheter is a Turnpike low LP. Turnpike LP is my catheter of choice.
So last comment from Himanshu, you wanted to make?
Just thank you so much for a nice presentation. I just noticed the case where you lost the stent in the circumflex when there was ostial LED stent.
Yes.
For the audience, I would say whenever there is a ostial LED stent, so many times it is protruding into the left vein because of the elongation or positioning. And when you have to deal with the circumflex in this patient, it's always better to put a wire in the LED first, or if you have imaging, check IVUS to see where the stent is. If the stent is coming in front of the circosteum, be very careful when you advance hardware into the circosteum like you did the next time with the guide extension. That is very important for whenever there is a stent at the ostium. If there is a side branch you want to deal, it is very important to define the proximal margin of the stent so that there is no interaction between the other equipment.
Yeah, absolutely. I mean, the whole point of demonstrating that case was the point that Himanshu just made, is that obviously it's all, you know, fun and games to try and get out of these situations, but the best option is never to find yourself in the situation to begin with. And so if there is an ostial stent there, be very careful and understanding that, you know, as you're taking more equipment in, there is the possibility of any interaction there. So you have to kind of, you know,
Thank you very much, Prashant.
Thank you.
With this, we close this session, and I'll thank all the moderators, chairpersons, and the panelists.